So it gives me great pleasure to invite onto his own blog, Faiez Zannad, one of the people that inspired me to become involved in clinical trials. Many of his clinical trials over the decades have cast light on management of heart failure in particular, in my interest. So Faiez Zannad, welcome to your own video blog.
Well, it's our both blog. It's your blog as well, Darrel.
Fantastic. That must be because you've just had some bills arrived and you're looking to share them out. Yeah? Yeah. Francis's law is that you understand things that were part of standard therapy when you were in medical school, because you had to read about all the mechanisms and draw the diagrams. Once you leave medical school, new things that come in, you sort of go, oh yeah, that thing, yeah, it's very good. You're never quite sure on the details because you never have to learn them. So SGLT2 inhibitor came out once I was already a professor, so there is no chance I will understand anything about them. Can you tell me what the motivation for the meta-analysis was?
Yeah, so the topic is SGLT2 inhibitors in heart failure with reduced ejection fraction, right? There have been many other trials in diabetes, but these trials are on diabetes and non-diabetes with the common ground of heart failure with reduced ejection fraction. When we got the EMPEROR-reduced results, well, there have been one trial before this, which has been published a year ago, which is DATA-HF. So now we have two trials in same space of heart failure with reduced ejection fraction with very similar drugs. Both of them are SGLT2 inhibitors. And each individual trial has reached its primary endpoint, which is CV death and heart failure hospitalization. So that's fine. But then if you really would like to get the grade 1A in the guidelines, you need to come up with more than one trial and hopefully with meta-analyses. Why is that so? Because one trial reinforces the other trial, and we call it the external validity, right? Number one. Number two is that if you combine the data from the two trials, you will expand the range of generalizability. With a wider spectrum of variety of severity of heart failure, in that case also a wider spectrum of comorbidity, including the renal dysfunction. So combining the two trials, we have a much wider range of severity of heart failure and renal function. But now the other thing is that the composite endpoint of CV death and heart failure hospitalization did not allow for individual powering for each of the components of CV death and heart failure hospitalization separately, right? And we have other secondary endpoints, and we have subgroups. So the trials are powered just for the primary endpoint and for the totality of population. Then if you need to understand whether there are subgroups which may benefit better, then the subgroups are not powered enough, and therefore pooling the data from two trials and doing a meta-analysis would give more power in order to check for the validity of the result within subgroup, and this we call internal validity across subgroup in each individual subgroup. And it would also give more power for individual components of the composite.
So by the sound of it, there's two motivations for doing a meta-analysis. Number one is that you increase the power. And in my mind, that's always what I've been thinking about, is that the purpose of meta-analysis is because individual studies are often powered specifically for an endpoint that you expect to have lots of events, so you have a chance of detecting with a reasonable cost an improvement in the endpoint, but often it's not mortality. And what you're saying is, as well as that, increasing the power for something like mortality and increasing the power to allow subgroup analyses on things like the primary endpoint, you also have making sure it doesn't just work in a particular group of people which happen to have been selected in a way that the investigators thought made sense, but happened to be using some kind of biomarker. And then when you apply it elsewhere, it doesn't work. So that's very important. So you had two trials of different drugs in the same class for broadly the same indication. And you put them together. Can you outline what the results of the meta-analysis were?
Yeah, so expectedly, of course, the primary outcome was only reinforced and the confidence interval was narrower because the magnitude of effect on CV death and heart failure hospitalization. So this is not really not a surprise, right? Now, for example, I'm just having two examples. One is the CV death, right? The CV death turned out to be significant in DAPA-HF on its own, not significant in EMPA-reduced. In the meta-analysis, the overall effect is significant with no heterogeneity, with no statistical interaction. This means that the results are superimposable with different power, but if you get them together, you have what we call the totality of evidence, right? So the totality of evidence, pulling the data together, showed that this, as a class, SGLT2 inhibition, may improve CV survival, right? So that's one example. Another example, which actually is good taken because it goes to the other way around. We had as one of the secondary endpoint the renal endpoint, which is a profound and sustained decrease on eGFR and renal death. And there was quite a handful of events in each trial. This did meet statistical significance in EMPA-reduced, but not in DAPA-HF, so the other way around than CV death. But pulling the data together showed actually it worked in both trials. And if you pull the data, the end of the day and the totality of the evidence is that both medication and SGLT2 inhibition in heart failure with reduced ejection fraction improve cardiovascular and renal outcome in this instance.
So Faiez, you made 2 points, and one of them is a great bugbear of mine. So excuse me while I know you know it, but so many fellows don't understand it. And rather than me strangling them individually, which has been my habit, let's actually point it out to them. So a lot of people say, oh, DAPA-HF, it really successful because look, oh, this is significant, yeah. Oh, look, it's not okay with that. And then, oh, but this is rubbish. This is all rubbish because look, it's not significant. So this trial shows this drug works, and this trial shows that that drug doesn't work. Yeah, that's not the way to do it. Now, Faiez knows, and I know, but a lot of people don't know. And the outcome of studies isn't the dichotomous outcome, but actually the point estimate and the error bar is the result of the study. And that one of the nice things about meta-analysis is not only do you get kind of the average effect of the two trials, which is this diamond, it's a sort of weighted average of the two. That's one thing you get. Second thing you get is an error bar, which is a bit smaller than the individual error bars because you have more information when you have two trials. But even more important, another wonderful thing about meta-analyses that I'd forgotten earlier was that it also tells you, are these two trials significantly different from each other? This is very important because when you see, particularly when you see one with an error bar just crossing one and the other one not crossing one, people get excited that one trial is positive and the other one is negative for this endpoint. In fact, do not get excited. Run it through this meta-analysis. It's effectively asking, are these two things significantly different from each other? And that is what the test for heterogeneity of effect is. It is testing that of the various trials listed, are they consistent with what you'd expect if it was one drug tried out in the same group of people, in a same case definition, but just run the trial many times? Is this what you'd expect? And if it's non-significant, it's telling you, yes, that it is consistent with being a class effect. And when you see a significant heterogeneity, it means at least one of the trials, you might have 10, is sticking out more than you'd expect, or there's more variability than you'd expect from those trials.
You need also to look at the test for overall treatment effect. And you can see here, P is 0027. This means that overall, if you pull the data from the two trials, there is a statistically significant effect on CV death, and it is estimated by the hazard ratio 0.86. This means 14% decrease of the risk of CV death. And this is statistically significant.
You get an error bar, and you know whether it's significant, and you get to be told whether it looks like there is significant difference between them. So it's actually very worthwhile doing that. There's two more things to it than what I had in my head when I started the conversation.
Okay, so in this slide, I have superimposed the bottom graph here, forest plots from another meta-analysis. And these are meta-analyses of SGLT2 inhibitor trial in type 2 diabetes, not heart failure, right? And again, you see that individual trials seem to be not so similar. Most of them had actually some positive effect on CV death, but only EMPA-REG outcome had a statistically significant effect on its own, right? So it goes the other way around, that what we have seen in EMPA-REDUCE, the EMPA-REG outcome, right? With empagliflozin is very effective on CV death in type 2 diabetes. It is effective, but not statistically significantly so in EMPA-REDUCE, right? So now look at the other trials. DECLARE with dapagliflozin, which turned out to be improving survival in TB death in heart failure, didn't look to be really impressively effective in type 2 diabetes. But this is the magic of meta-analysis. Look at, you pull the three data from the three trials, which would total up actually over almost 20,000 patients, then you will find out actually there is no heterogeneity. All three medication, and actually as a class, they do improve TB mortality, and this is statistically significant without heterogeneity. So it's just in order to say, well, it's a matter of luck. Occasionally you can hit statistically significant and other time you don't, because this is not the primary endpoint. So there is less power, and this is the way where you look at the totality of evidence, and you need to look at every bit of information there and putting them together, no heterogeneity. And overall in type 2 diabetes, but also in HFrEF, these medications have a significant effect on CV death.
Great. So actually, this shows a very nice Canvas and DECLARE. Were they heart failure as well? Or
no. All the three trials are in type 2 diabetes, not heart failure.
Okay. Well, what's interesting is you see in the diabetes studies that overall there does seem to be a significant reduction in cardiovascular death. So actually, Faiez, the slide of yours shows the other side of the coin as well, which is that when you look at the diabetes trials, there are three trials of patients with diabetes. This isn't heart failure, it's diabetes. Three trials of SGLT2 inhibitors, and what they show for cardiovascular death endpoints is these results. And there's a significant reduction in one of the trials, EMPA-REG outcome, and no significant reduction in the other two trials. When you put the three together, the combined estimate is 0.80, which is statistically significant. But this is the point that Faiez was making, that when you do the test for heterogeneity, and that's what this thing is, this Q statistic is one of the many possible tests for heterogeneity, but this one is significant. And what that's telling you is these three results, these three error bars, are not entirely consistent with each other. That is, if you took the same drug and you tested in very similar patients in three trials of this size, you would not expect them to wobble this much, is what it's telling you. And it tells you that this I-squared value is telling you how much of the difference between the trials is likely to be because the patients or the drugs were a bit different, as opposed to being random variation. And that's actually quite interesting. So if I was looking just at the diabetes, I would then be delving into exactly the drugs and how they found these patients. But thank goodness we are not, because we are cardiologists.
Yeah, so that's great explanation, Darrel. But in the point I wanted to make here is for people who are making the emphasis that in HFrEF, only DAPA is producing a significant effect on CV death, but not EMPA-REDUCE. But then we have discussed about the totality of evidence here.
And that's why we have the meta-analysis, because we can show that these are not significantly different from each other.
But in addition, it happens that in diabetes, empagliflozin turns out to be the most highly significant effect on CV death.
Very interesting. Very interesting, yes. So there's a good chance that there's a big element of play of chance in the apparent differences between the two.
It's just a matter of point and counterpoint.
Now let's look at this kidney composite, because I find this puzzling, because to me, all I think about in SGLT2 inhibitors is it just makes more glucose go out in the urine. And if you asked me what the likely effect that would have on renal endpoints, I wouldn't have assumed it would have any sort of advantageous effect in that direction. If anything, it would give you, like, urine tract infections from bits of glucose or something. But I would have guessed neutral. So tell me what you found here.
Yeah, well, just relative to the effect on glucose, we are pretty sure now that this is in no way the explanation of the benefit of this class of drug on cardiovascular prevention in general and in heart failure in particular, because in heart failure and emperor-reduced and DAPA-HF, we have enrolled patients with and without diabetes, and the benefit was consistent in diabetes and no diabetes. And we have also looked at the benefit as a function of baseline glycated hemoglobin and as a function of the effect on glucose and glycated hemoglobin. And there were not a single signal that lowering glycated hemoglobin or glucose can explain in any way the clinical results we are seeing. So it's pretty much many other mechanisms of action, but certainly not glucose lowering.
That's really sad. It's like, I only had one piece of knowledge in my head about SGLT2 inhibitors, and that it turns out to be wrong.
So you need to add a few more in your head. Getting to this slide, it's another depiction of the effect which is far beyond glucose lowering. This is kidney protection, right? We say kidney protection because the nephrologists are angry against us when we use the term renal. They are shifting away from renal. So everything, don't talk about cardiorenal syndrome anymore. It's cardiokidney, right? So this is the, so getting to this first kidney composite, it is a sustained and profound decline of eGFR. Here it was about 50%. And or getting in end-stage renal disease, this being entering in dialysis, or renal death, this being dialysis, which is followed by death. So this is a composite again. And this composite actually, of course, is individual trials were not powered enough. And you can see actually the numbers, 18 cases in one slide and in one arm of study and 33 in the other arm. So it's a handful. And it's just by chance, and because the effect was so powerful, 50% decrease, that it turned out to be significant in emperor-reduced. Now, directionally, we have the same kind of result in DAPA-HF, except that it didn't hit the significant margin. But again, if you pull the result together, you end up by showing exactly what we have seen in the CV death story. Same story, these two drugs together across a large spectrum of kidney diseases and heart failure severity, they are kidney protective.
So Faiez, you also did an analysis of whether different classes of patients benefited differentially from SGLT2 inhibitors. Can you take us through those results?
Yeah. Well, one point of recollection, which is very important, is that these two trials enrolled patients with really low eGFR with some sort of CKD. Actually, more 40 to 50% of patients had a history of CKD in these HFrEF trials, and eGFR inclusion in emperor-reduced was as low as 20, and it was as low as 30 in DAPA-HF. So these are actually really low eGFR, which is great, right? This means that we will be able to generalize the result to patients with some sort of CKD and low eGFR. Now, taken together, and if you pull the result from emperor and DAPA-HF again, you can see that consistently in patients with and without CKD, with eGFR below 60 or above 60, the benefit was consistent in the primary endpoint of CV death and heart failure hospitalization. And therefore, the cardiovascular benefit was consistent across a large spectrum of renal dysfunction. And actually, in the single trial of EMPA-reduced, because we didn't have a patient-level data in DAPA-HF, so we did the analysis only in EMPA-reduced, and we have actually got to quintiles. And across the 5 quintiles of eGFR, the benefit was very, very consistent on the primary endpoint. So very important to have the totality of evidence again across a large number of subgroups. And this is also the magic and virtue of beta analysis. Again, if you don't have enough power in each individual subgroup, you pull these different subgroups in 2 trials, and then you may get closer, what we call to the truth. And this is what my dear friend Stuart Parker says, it is regression to the truth. And that's the interest of beta analysis.
Very, very good. So again, this is a particularly elegant slide because it shows how you can test interaction at 2 levels. So what it shows is patients in EMPA-reduced divided into those who have low eGFR and those who don't have low eGFR, and DAPA-HF, low eGFR and non-low eGFR. So you have 4 subgroups, as it were, 4 chunks of patients who were randomized. And then you have 4 individual results, and then the 2 pooled results of low eGFR and the 2 pooled results of not so low eGFR. And remember what we said, when you want to see if these 2 drugs are different in this group, instead of just eyeballing it and trying to make something up, you look at the meta-analysis heterogeneity test. And what this is telling you is they are not significantly different from each other. And neither are these bottom 2 different from each other, as you can see here. And then at the next level of comparison is the top half of the screen are these 2 up here, different from these 2 down here. And that is test for treatment by subgroup interaction. And that's not significant either. So what that's telling you is, yes, there is a benefit and a hazard ratio of somewhere around 0.75 for the whole lot together. And it doesn't matter which drug you take, and it doesn't matter what level of eGFR you're at. It works just the same. It's quite remarkable. Now, you also did a similar type of analysis, Faiez, for diabetes. And actually, now that we know the structure of it, it's really easy for the audience to see what's going on, because what you show is that regardless of which drug, the result is the same. They are not different from each other. They're not heterogeneous apart from each other. And regardless of whether you have diabetes, it is not different from each other. And that's quite remarkable. Well, it underlines your point that this is not a glycosuria agent in this indication.
Yeah, and this slide doesn't add much to individual trials because, of course, the individual trials were powered enough in order to look into this subgroup analysis. But what it does show is the consistency among the 2 trials, and this is what we say external validity. So this means it only increasing the robustness of this observation that the benefit is independent from the diabetes status.
And then one final meta-analysis you have included in this bumper meta-analysis slide set. And one final meta-analysis that you've included in this set is stratifying by patients whether or not they're taking ARNI. And could you tell us your highlights from this one?
Yeah, well, actually, it is very, very important and practical question. Does the benefit from SGLT2 inhibition is additional to ARNI, or should we consider either or, right? So because ARNI are not around for so long, and the implementation, and I must say to my regret, because I mean, the implementation is really lousy, and we should, as a major lesson from this discussion, switch most of our patients, if not all, from ACE-ARBs to an ARNI. And that's a high-grade guidelines. But this is real life, and the real life within these trials is that only a minority of the patients were on ARNI, maybe between 15 and 20%, right? This was a small subgroup, and if you look at the individual trials in DAPA-HF, patients who are receiving an ANI, they didn't look to benefit if you have a first look at the result, because this confidence interval, as you have seen, crosses the identity line, right? But again, EMPEROR-Reduce in its own did show that the benefit is additional, right? But again, the totality of evidence is that the pooled analysis, the confidence intervals do overlap, and you can see it on the test for overall treatment effect is highly statistically significant, 0.043, and a test of heterogeneity, no heterogeneity.
And what that's telling us is these diamonds are well away from the neutrality line, and they are no different in position from each other than one would expect.
So whether patients are not receiving an ANI, like on the bottom of this slide, or are receiving an ANI on the top of this slide, they all benefit almost equally. This we don't have an answer. Yeah.
So Faiez, this is one analysis that doesn't fit the mold of what we have just spoken about. What do you see here?
Well, actually, we have looked at other subgroups, and a subgroup based on New York Heart Association classification, which is functional capacity. And you can see here in each trial, individual trial, the drugs seem to benefit more a patient with class 2. The benefit seemed to be smaller, and if any, in this individual subgroup, not powered enough, not statistically significant, right? Now, if you can see this in one single trial, we try to guess why the hell that people more severe do not benefit as much as less severe, right? You need to come up with a mechanistic plausibility, or you just walk your way and say, well, this is subgroup analysis. We don't believe in subgroup. It may be chance finding, right? Now, the issue is here that these interaction, we have seen it in the two trials, in both trials. Now it becomes really a headache. This is a persistent signal, right? Across two trials, two drugs, in two different populations, you have still this persistent signal that patients with more severity tend to benefit less, right? And I really don't know why that's so. And we need to look at other ways of looking at severity. And if you look at NT-proBNP and other, sign of severity, the MAGIC score, etc., we cannot reproduce this, that patient with more severe benefit less. So we will have a question mark here. But what is puzzling is that, yes, this is a persistent signal across the two trials.
And so for the benefit of the fellows who were explaining how to interpret the meta-analyses, what we see here is these two results here are consistent with each other because there's no heterogeneity between them. Likewise, these two here are consistent with each other because there's no heterogeneity with them. However, when you look at this clump and compare with this clump, by eye, you can wonder, are they sort of different? And they might be, you don't know whether you're over-interpreting, but that is why you have a formal test, which is a heterogeneity between the top half of the screen and the bottom half of the screen. And so this tells you that there appears to be a genuine difference in the effectiveness, the relative effectiveness of the drug in class 2 versus class 3/class 4. Also interesting to me because class 2 versus class 3 is the most difficult clinical decision to do consistently. As I say, when I got fellows to do a little study where they classified patients in the heart failure outpatients as class 2 and class 3, the agreement was something like 55–60%, which sounded good, but actually tossing a coin would be,
right.
be 50.
Yeah.
And I say, well, because class 1, the cleaner can detect because they are just running around. The janitor can diagnose class 1, they feel normal, and the janitor can diagnose class 4 because they're in a wheelchair or sitting breathless at rest. So the whole point of going to medical school and training in cardiology is to distinguish between class 2 and class 3. And we are not that good yet. Even though we don't agree with each other as to who is class 2 and class 3, somehow that categorization is extremely important prognostically and picks out a distinction between patients who benefit and not. And obviously there's class 4s as well here, but there are other examples of studies where stratifying between 2 and 3 can make a significant difference in efficacy.
Now, this slide is something different because I would agree that actually distinguishing between class 2 and 3 New York Heart may be tricky, but distinguishing between white and black is not tricky, right?
Well, it depends. It's not in America or maybe in France, but in London, we have a fantastic statistic where in the UK, in London, 2% of people say they're mixed race in London.
Oh, that's right.
Well,
you've got a point.
Of people
so you've got a point.
Parents are of different races. They want to be mixed.
So you've got a point. But here is another persistent signal across the two trials, again, where white patients seem to benefit less than black and Asians, right? And this wasn't in a single trial, it was consistent across the two trials. So why that so? We still have to find out. And actually, we did try to look whether this is related to the country geographical distribution rather than ethnicity.
Yes.
But we have this, and we have looked at the Eastern Europe versus Western Europe, etc. It did turn out to be geographical, and actually more than geography, what is most important when we do this geographical or country subgroup analysis is because the healthcare system is very important, and it's a really very important determinant outcome and may play a role in the benefit of medication. But it turns out to be that it's not geographical distribution, it's really ethnicity here that is showing some difference.
So this, along with the hydralazine and nitrates, is probably the strongest example of an ethnic difference in an effect on.
Well, it's much less strong than the hydralazine nitrate. The hydralazine nitrate, we have got an explanation. We have a mechanistic plausibility, and we have genetic explanation of interaction with the beta receptor and with nitrates. There is a mechanistic plausibility. Here, we still have to find out whether it is true.
We still don't know how the thing works. So, yeah. But in fact, the first time I met Faiez in person, it was when we were arguing. We weren't arguing. We were both on the same side, where there was a group of experts and me were talking about mechanisms. And then they were all giving their mechanisms. And he says, I don't believe in mechanisms. Everything everyone says about mechanisms is bullshit. I said, I love that, man, because I always thought that when you go to a lecture and they draw all the lines where this goes to this and cyclic this comes here and this goes up, we just nod. But if they turn the arrows round or said it goes up or down, we would also still nod. We don't know if that is actually why the drug is working.
Well, Darrel, you are slightly misquoting me, by the way. But I say
you don't believe in claims of mechanism.
That's right. I don't pay much attention to it because, but that's really specific to my heart failure background, because any drug we have developed under the basis of mechanism, right? Positive inotrope, vasodilators, which we meant to target a mechanism in order to improve the condition of heart failure patient. We failed, right? Yeah. And now, incidentally,
and we were terrified to give beta blockers to people.
That's right. That's right.
It used to be a pass-fail question in medical school.
But now the other way around, that it incidentally, and what we call it serendipity, right? We were sailing for glucose lowering, and all of a sudden we had a continent which is not India. It had heart failure, and this medication are heart failure medication, not only glucose lowering. And the same story goes the same with beta blockers and got the same with ACE inhibitors, which were developed for hypertension first. Wow. And no one would have thought that the beta blocker, which is a negative inotrope, would be effective in heart failure patients. So that's the reason I'm saying I don't pay much attention to mechanism of action, and I would rather believe on the result. If a drug works, and this is what clinical trials are telling us, they tell us whether the drug works or doesn't work. They don't tell us much about mechanism. So
no, we can make you can make a list of mechanisms. Then once you know the result of the trial, you decide which mechanism slide to put up. That's the problem. And then people believe that the mechanism is somehow...
And there are lots of very smart people, when they have a trial, they can draw a fantastic slide with arrows, colors going in all directions, and people say, "Oh, that's really great."
You know what? When I interview for trainees, I wanted to include a thing where a kind of aptitude test, where what I do is an hour before the interview, you give them a drug and a disease at random, and you give them a computer and the internet and PowerPoint and ask them to make in the next hour a presentation why this drug is probably going to be good for it. Yeah. And then they have to do it. But then 10 minutes before, you say, sorry, it's the other way around. Can you show why it's going to be bad? Yeah. And that's
not a problem.
I think they would do really well, because you just look up random mechanisms, you discard half of them because it's the wrong way around, but then you go and get them out of the wastebasket. You could produce a brilliant tool.
Wow. This would not please my colleagues from basic science, but okay, so you can tell them.
Yes. We must do another session where you go through the history of how we discovered this, how we discovered these drugs were going to be useful, because
that would be really entertaining. Yeah, I would love that. We
often put up the slides as though this is how it all happened. Whereas, you know, the physicists and the chemists give a very nice story of how they discovered things, and they're very excited about it. Whereas we kind of cover it up and sort of present it as though the information came from on high, that Faiez Zannad thought spironolactone would be very good. And just from the first principles, thinking about the biomolecular structure, but actually it is from piecing together observations where they were unexpected and then deciding to do a trial. Thank you very much, Faiez. It's been fantastic to see your insights into SGLT2 inhibitors, and also to get a chance to show the fellows how to interpret a meta-analysis and why they can be useful. I know some people scoff, what's the point of a meta-analysis with 2 studies? I hope they have all learned something from this, as I have. And thank you very much for giving us your time.
Thank you so much, Darrel. Actually, you helped me achieve the double target of a trial, help people treat patients better, but also help fellows understand the science. That's really the 2 main aims of trials.
Fantastic. Thank you so much. Bye-bye.
Thank you. Bye-bye.